Very good afternoon to one and all. At the very onset, I should thank ROGS and especially JP sir for giving me this opportunity and learning about anemia since our UG and more about it in our PG days. My beloved sir, Virendra sir is here. I'm glad that sir is here and both sir are here to listen to this. So the topic given was refractory anemia. So I actually, if you go into the literature and you type refractory anemia, it tells you about the myelodysplastic syndrome. It is not about what we want to talk it in our general terminology. That whatever we are trying to give or whatever we are giving to improve anemia, it is not improved. So if you are not a hematologist, this terminology is going to be a bit difficult to understand. For a hematologist, refractory anemia is something which is related to the bone marrow where they are dysplastic and especially the red cells are not growing from there. So it is a different entity. So I will take into that area where we will try to, because we do obstetricians, we are trying to cater to this population that is in pregnancy. So what is refractory anemia in pregnancy? So about the introduction, I told about refractory anemia. The terminology may not be that evident for us, but in pregnancy, what are the causes? So one is anemia, which is associated with chronic disorders. Anemia are showing hypoplastic or aplastic changes. And one important entity I want to bring out today is something which is iron refractory iron deficiency anemia. So we are bombarding with so much of iron, but that is not responding. And some miscellaneous refractory anemias and the summary. So we all know whatever it is, any pregnant woman, if otherwise proved, she is anemic. So in that anemia also, being nutritional anemia, that is iron. Iron is the most common cause. So we are bound that every obstetrician in the entire world, I believe, they give her iron supplement. So most of them, we start them with iron supplement by oral, as what sir had put from in the clinical journal, the update that oral iron is the most safest and cheapest, and at times it may work, may or may not work. Yes. Parental iron, only when we think that it is not working, we go. So now, after doing all this, we started looking whether when she comes back for her, we got her CBC done, and the anemia is not improving. So where has the iron gone? So we need to bring to the criteria to understand how a refractory anemia is. To put it in simple words, this anemia is not responding to the conventional treatment that we are giving with respect to iron and other medications. At times, it will be effective only when we give transfusions. So, it is the appearance of anemia that is appearing only during pregnancy, and after pregnancy it is going off. So, it has proved refractories to the various modalities of treatment that we are given. Here in this patient, you have a normal iron load or normal or elevated serum iron level in them. So they will have thrombocytopenia and granulopenia, and the bone marrow usually will be normal plastic. So it was, if you look into the literature, it was Roy from US who made this study in 1960, and he gave these definitions to understand what is refractory anemia in pregnancy. So he characterized it recurs with each pregnancy and it undergoes the various pathological changes and has its remission once the pregnancy has gone. So yes, definitely it is not because of iron deficiency. You have normal ferritin and normal transferrin saturations as well. There is bone marrow changes with respect to hypoplasia of the only erythroid cells. So this is what small chart we want to add upon, that anemia of chronic disease or myeloproliferative disorders. One thing I have to share, that is iron deficiency, iron refractory anemia, and the miscellaneous causes. So chronic disease, we all know, we try to treat the patient as sir was discussing. We might be having some clinical infection in the patient and we might have missed that. So most common what we have in Indian population is the TB, some kidney renal disorders, and HIV, which we sometimes don't take the history properly or we do not got the serology proper, then chronic inflammations. So another important entity we need to look into is the systemic, the connective tissue disorders like the SLE, rheumatoid arthritis. So these things have to be kept in mind. Why? I'm sorry. Why? So why it is common in chronic disorders? It is known because there is disproportionate rise of plasma level, plasma volume in contrast to the red cell mass expansion. So in chronic inflammation, it is a long-term inflammatory changes that is occurring, and so these people won't respond to our normal usual treatment what we give. So I will touch upon only those areas because all the other areas which I'm trying to, I cannot cover all the areas where we are not able to treat because this entity will require not only the obstetricians to treat, we will require a specialist to come into and we will make. So some entities which we know, like example HIV and anemia, why they are so common in that? One is the inflammatory process definitely. Another is uses of the drugs, especially the zidovudine and lamivudine. So zidovudine and lamivudine, these days we got to know the three drug combination what we are giving. Especially zidovudine is known to cause myelosuppression and they have anemia. So this usually begins after they have taken the treatment for more than 3 months. So one is the autoimmune response because of the dysregulated immune system they have the HIV patients, and another is because of the drug. So that is because of myelosuppressive effect of the ART. So in such patients, we are not bound to do a bone marrow examination, taking a proper history with these drugs if they are on the regimen. Stopping these drugs or taking an alternate regimen for them, for these people, can definitely revert back to the anemia. So what do you know about in chronic disease is that, so here they will have chronic anemia, definitely, but they have a normal iron, the serum iron concentration, though maybe it is reduced, but the iron binding capacity will be lower than the normal. That is usually will be more in comparison to your normal iron, in comparison to your iron deficiency anemia, where the serum ferritin level, which is always less in most of us in the iron deficiency, here it will be more. So this is how we take about in chronic diseases. So one of the treatment modalities they have told is not just putting into iron. We can use the recombinant human erythropoietin in such cases along with the parental iron. So blood transfusions are only required only in cases of severe anemia. The importance of adding blood transfusion talk here is we give transfused blood even in a hypoxic state only to increase the oxygen carrying capacity to the major organs. That is one of volume load can be replaced by other crystalloids, but in cases where you don't find with severe anemia, when the patient is having other very bad prognostications, then you can go for iron deficiency anemia. So role of erythropoietin, still it is in research phase, but still in India it is available now. It depends. Even Bharat Serum has come up with the various dosages. They usually give it around 10,000 based on the weight of the patient. So it is given subcutaneous a single vial. But the studies are not that good enough to say that we can recommend this in pregnant women. But yes, refractory anemia in case of pregnancy, when it is taking or pregnancy is getting affected, we can go for erythropoietin. So before erythropoietin, we have to rule out all other things the lady has, whether she is having the causes of other causes of anemia like vitamin deficiency, metabolic or chronic disorders, and look for those transferrin saturation should be at least 20% and ferritin should be at least 100 nanograms. So these are all smaller ones, but not that evident to say that these usually will be diagnosed prior to pregnancy, like the aplastic anemia, having the bone marrow pancytopenia, and these are usually rarely seen in high in pregnancy. So causes in aplastic, just to put for this slide, one is you have to think of the drugs whether she is having any long-term or early any infections, whether she is exposed to irradiations, or is she associated with any myeloproliferative disorders or inherited disorders as Fanconi's anemia. So management here again, they usually do not respond to any erythropoietic agents. So we can try anti-thymocyte globulin, which is showing good results, and immunosuppressive agents like cyclosporin can help in these patients. Corticosteroids, yes, definitely. So yes, today if I want to discuss about refractory anemias, as I had a discussion with our Balram Singh Thakur sir prior to the session. So what is that we need to look into? I'm not putting a slide of the CBC. I just would to say in our CBC we get to know about the various parameters. If you want to really look into those things in our CBC, if you want to look those, one is the HP, then look for the MCV, then you have the red cell distribution value. So if you have a lady and invariably, even if it is anemia of 8 to 9 around, we start her on treatment. So we have given her almost 1 month and she comes back. So her HP is same 8. And at that time we may have to look back into our CBC whether I have looked read my CBC properly. So go into the MCV and look for the MCV. So we one of the parameters we read was showed about Menzel's index. What is MCV about RBC? So usually what is known is that in thalassemia patients, the RBC counts are bit higher side. Maybe what we have between 3 to 5.5, they usually have around 5.5 to 6 millions. Why is it so? Because there is because of the hemoglobinopathies, the elevated these nucleated cells, the hemolytic cells, sometimes they are calculated by the automated sellers as RBCs. So they have more RBC values. So if you can plot that, if you put CBC, what is that, MCV upon RBC, and if you get more than 13 or less than 13. So if you have more than 13, you can put it as iron deficiency anemia, or if it is less than 13, you put it as thalassemia. But it is not confirmatory, but it is only to say that my patient is not getting improved with the treatment that I am giving. So based on this Menzel's index, I am thinking in terms of thalassemia, I will speak to the pathologist or the hematologist to work on. So as what sir told, the best would for them would be to go for HPLC, that is liquid chromatography. Only then we will come to know that it is thalassemia. So why am I putting only thalassemia trait? That sir also told. Thalassemia trait is one important entity we are often getting in pregnancy, which we have missed prior. But what about thalassemia intermediate and thalassemia major? Definitely those patients would have been diagnosed prior to the pregnancy. They would not have been, they would have had history of transfusions, they would have been worked up properly. So this is one entity where our anemia falling in the range of mild to moderate entity, which is not getting improved based on this. One more entity was sir put up 2 cases. The first case was severe anemia, whereas the red cell distribution width was more. It was more than 15 centimeters. So in your report, you can also look into that. Again, HP, MCV, then red cell distribution width. So if the red cell distribution width is falling within the normal range, then you can think in terms of thalassemia. If the red cell distribution width is getting more than 20, think in terms of iron deficiency only. So we have one more entity, that is refractory iron deficiency anemia. So now on the parameters we made, it is iron deficiency anemia. We are going to rule out thalassemia. So then what it is, even after giving so much of iron, the patient is not getting improved. This is a newer entity. So it is a rare genetic disorder. It is autosomal recessive, and the incidence is very less. And very few research papers have come up. This is all from the hematology group of people. So here, this particular genetic this protein is got polymorphs. That is PMPRSS gene. There is polymorphism of the or the absence of this gene, which is affecting the transport of some protease enzyme for intestinal iron absorption. This is linked with your hepcidin block theory also, where now what they are telling is they have so in this, the degree of anemia is refractory because to the oral iron treatment, but may partially respond to the IV treatment. So in such patients, invariably, in our clinical practice, it's not that evident because when we are thinking in terms of iron deficiency anemia and we have ruled out other causes, we are bombarding them with the parenteral iron. So there is transient improvement. Maybe in this pregnancy, she will get improved. This will walk through her pregnancy, her delivery. But for her, the treatment of choice still today for this kind of refractory anemia is the parenteral iron. But research is still going on to work out with the hepcidin molecules, where to maybe the isomaltoside is what you are telling, sir. That molecule they are trying to, because that is going to transpass that pathway. So they are looking into that angles of bringing out those molecules which will surpass the hepcidin pathway.
They are only hepcidin blockers.
Yes, sir.
Antagonism hepcidin.
Though they are in research phases. But the entity which I have shared today, maybe we may pass the lady with giving some good parental iron. Even if it's not working, we can transfuse her. She will come out with the pregnancy, but that will not stop there. Maybe she'll come up again with the same entity. Then we may have to involve a hematologist for that. So this is a normal slide to know about the bone marrow in pregnancy because pregnancy itself has its anything is going to put it higher. That is, we have a slightly hypercellular bone marrow. That is the reason why we have more of megakaryocytes and bone marrow in hypercellular because of increased granulopoiesis, because this is normal physiology. So one entity about hypopheric anemia or hypoproliferative anemia. In metabolic states like endocrine deficiency, this condition is a known entity, and maybe if it is not iron which is that we are bombarding, we may have to go for blood transfusions in such cases. So these are again chronic liver disease. So my take today will be to how to differentiate a normal iron deficiency anemia, which is very common, and then thalassemia. As what Balram sir stressed upon, whatever may be the anemia, even if you have not ruled out thalassemia, but treat iron deficiency anemia first. That is what we usually do. We give her iron because we may lose, because sir told if you don't have that particular saturation for the transferrin, the HbA2 levels also may not be picked up when she is severely anemic. So what we are doing is, one way we are right, we are treating her anemia, and later that we are coming to know that her anemia is not improving, then we are going for her further investigation. So those smaller indices like the Menzel's index or looking at the red cell distribution within our normal CBC report will help us. The summary is, these are usually uncommon during pregnancies. Maybe we have to spend time with our CBC report again and again. Blood transfusions are sometimes required for conditions which are not effective with our modalities. Bone marrow transplantation is the ultimate treatment, what they say, when they are not refractory to anybody, but in pregnancy, it is not that feasible. One entity to discuss today was the refractory iron deficiency anemia. Because of the genetic association it has, it is autosomal recessive. Thank you.